I'm going to talk about anesthetic issues. After a number of years in the university system, we learned to call complications and problems issues instead of problems because it sounds a lot better, and everybody gets along better then. Naturally, people who are in the anesthesia specialty think anesthesia is just the coolest thing in the world, and it is. And every now and then, though, it's a little bit worrisome, and occasionally, rarely, bad things do happen. And that's one reason that we're having a discussion tonight, is because on occasion, bad things happen, and it makes us nervous. Anesthesia scares me. When it stops scaring me, I'm probably going to need to stop doing this for a living, and it should probably scare all of you too. Because what we're doing is bringing animals closer to death than they're ever going to be during their life, and then bringing them back to life again, and that's a pretty scary thing. We were having a discussion just today. Trey and I, we try really hard not to get along on anything, but we were having a discussion with one of the technicians about what was more important, surgery or anesthesia. And I did have to admit that even though it's just the coolest thing in the world, and just to anesthetize something and let it lie there and see what happens, anesthesia is a means to an end, and we are doing this for a reason, and it's usually for some diagnostic or surgical purpose, and I had to admit that, although I didn't want to. So tonight is the first part of a two-part discussion. We're going to talk about the incidence of bad things happening, and talk some about how we can either hopefully prevent or treat some of the complications and issues from happening. And I'm going to approach it from the body system standpoint. And in June, I'm going to talk more about approaching issues from the drug standpoint, and also give an update on cardiopulmonary cerebral resuscitation. So does mortality occur in anesthesia? Yes, it does. Well, how often does it occur, and what makes it happen? We try to approach things in veterinary medicine from the evidence-based standpoint now. So I'm going to talk to you about what some of the studies in both human and veterinary anesthesia have told us in the past and these days. From the veterinary mortality standpoint, historically, there were some studies done back in the 1980s and the 1990s, and the mortality rates were pretty high, anywhere from a 0.1 to a 0.4% mortality rate, and that is significantly higher than human anesthesia mortality rates at the time. Back then, most of the problems were either related to sick animals or to the drugs that were used. Xylazine was associated with a higher mortality rate. Halothane was associated with a higher mortality rate. And the use of acepromazine and atropine were associated with a reduction in the mortality rate. And in those studies, cats had a higher anesthetic mortality rate than dogs. And that was, 20 to 30 years ago. So what if you guys went under anesthesia? Well, they've been doing human anesthetic mortality studies for a long time, and the perioperative anesthetic mortality rate for about the past 50 years has been much lower, thank goodness, in humans than it has in animals. It's been about 0.01%. Yeah.
That's quite so early. So, is that all animals, or is that healthy people, healthy animals, or like anybody that undergoes?
In those studies in animals, that was all the animals in those studies. In these studies, that's all people.
It doesn't matter, they could be the sickest of the sickest.
Right. But I'm going to break it down a little bit here now. If you're a healthy person, it's much better. So if you're on, and I'm going to go into ASA risk status numbers here in a minute, because we use these numbers in veterinary anesthesia too, to associate your health status and what kind of risk you're going to be under anesthesia. So the more recent studies have shown that your anesthetic risk, if you're a healthy person, is much lower. So you've got about a 1 in 100 to 400,000 chance of dying under anesthesia if you're healthy. So try to stay healthy. The things that cause issues or complications are airway issues, ventilatory problems, circulatory failure, and that's usually associated with drugs. There are allergy problems in people a lot more commonly than animals. We don't see very many anesthetic allergies, but in people there are some. And adverse drug events occur. And most of these problems all fall back to human error. Almost all of the problems that I've listed there are associated with human error. And I want to talk a little bit about this anesthetic risk assessment because it falls into play later on in the discussion that I'm going to give. And it's something that we in veterinary anesthesia use pretty much every day when we take a look at the veterinary patients that we anesthetize and we assign them a risk status. So the American Society of Anesthesiologists has assigned an ASA physical status risk, and it's a numerical assessment, and it's based on physical, subjective, and objective findings of the patient that presents that's about to undergo anesthesia, and we use it also in veterinary anesthesia. And it goes from a 1 to a 5, with 1 being a normal, healthy person undergoing some elective procedure, like you have a meniscal tear. But it's really not hurting you, and you want to go in and have arthroscopic surgery, and you're normal, perfectly healthy in every other way. 2 is some local problem, like you're a little kid, but otherwise you're healthy, and you're having your tonsils out because they're hurting you. 3 is some systemic disease, but it's not a constant threat to your life. 4 is something that's a threat to your life, and 5, you're moribund, you're in a coma, and you're not expected to live for 24 hours whether they intervene or not. And E is an emergent status on any of those numbers. So let's say that you're a 75-year-old man and you're a smoker and you've got COPD, and you've also just been in a car wreck and you fractured your femur. What physical status do you think the anesthesiologist is going to assess you when you go to the hospital? Let's say that you're not in hypovolemic shock, but you've got a femur fracture that's got to be surgically repaired, and you've got COPD, and you're 75 years old. You're probably going to be a good solid 3, because none of those problems is a constant current threat to your life, unless you're also bleeding from that femur fracture and you're hypovolemic. That would put you in a 4. And if this surgery is an emergency, you are a 3E or a 4E. Okay? So it pays to not smoke, because that COPD just bumped up your physical status from a 2 probably to a 3 or a 4. And that also just bumped up your ASA mortality risk from that 0.0004 to a 0.01. It just increased your likelihood of dying significantly. So in humans, it pays a lot to be healthy. So in veterinary medicine, this is sort of how we use this ASA status, and I use it every day. Even if I don't physically write down or circle that number on our anesthesia record, I will mentally run through every patient that I anesthetize, and I will mentally assign them a risk status. And the higher that number, I will mentally go through a mental checklist of drugs that I'm not going to be using on that animal. And that leaves me with another list of drugs that I think, okay, these are the drugs that I can use. And that also gives me a mental list of what problems can I expect to happen in this animal because it's an ASA 3 or an ASA 4. And that also gives me a mental checklist of how I'm going to prepare for that animal. So I use this classification every single day. So let's talk about current studies looking at veterinary mortality. We do have current studies looking at veterinary mortality. The study by Broadbelt in 2008 looked at almost 100,000 dogs in the United Kingdom. And this study came out in 2008 in JAVMA. He did look at the dogs in 2002 to 2004, so the study is a little bit dated, even though it didn't come out till '08. Out of 98,000 dogs, he had 148 deaths, 0.15%. Hasn't changed much in 20-something years. We still have a 0.15% mortality rate in dogs. And here are the factors, at least in that study, that increase the likelihood of these dogs dying. That ASA status, so the sicker they were, and that's common sense really, the sicker they are, the more likely they were to die. But they were 6 times more likely to die each time their ASA status increased. Their likelihood of dying would increase 6 times. The urgency of the procedure, so if it was an emergency, they were more likely to die. If they were greater than 12 years old. Now, we used to say that age was not a disease and that it did not make you more likely to have a problem, but this study has disproved us there. So age does. And in this study, these animals were 7 times more likely to die than dogs that were of normal age, that were less than 5 years old. And small body size. If they were less than 5 kilograms in size, they were 8 times more likely to die than dogs that were 5 to 15 kilograms. So major versus minor procedures too. If they were undergoing something major, and that's kind of common sense too, they were 5 times more likely to die than something that was undergoing a minor procedure. And halothane too. We don't have halothane available anymore, but they were more likely to have an increased mortality rate if they were being anesthetized with halothane. But it's interesting that they also looked at a number of induction drugs, and this was the only drug-related increased mortality risk. Everything else was animal-related. So what about cats? Another study, same group here, looked at cats, and they just reported this in '07, and this came out in a human anesthesia journal. I thought that was kind of cool that they applied to and were accepted to a human journal. And the British Journal of Anesthesia is a pretty big journal. They again looked at cats, same time span. They looked at almost 80,000 cats and pretty high mortality rate, 0.24% mortality rate. So what kills cats? Kind of the same thing. Poor health and age extremes. If you're a cat and you're over 12, you're twice as likely to die as if you're a young cat. If you're less than 2 kilograms, you're 16 times more likely to die than if you're a normal weight cat. So don't be a little cat. Look at that. If you get intubated, you have an increased likelihood of dying, at least in this study. And probably some of the things are rough intubation, like tracheal tears, maybe laryngospasm, things like that, and IV fluid administration. That was counterintuitive, and that was a surprise finding here, and they think it may be due to fluid overload or something like that, but that was an increased risk factor, and that was an unusual finding.
Do you think that there could be any correlation with the fact that we're giving IV fluids to animals we think are sicker to start with? So skewing your population?
It could have been, but they didn't necessarily see that correlation in this study. But that was a really interesting finding that they saw there, and the intubation too. But the other thing to keep in mind is that when you look at AVMA professional liability suits, intubation injuries in cats and tracheal tears are some of the lawsuits that we do see occasionally there. So that's another thing. If you're going to intubate a cat, you just need to be very careful about how you do it. And I'm certainly not saying that we shouldn't intubate cats. I'm saying that we need to be a lot more careful about intubating cats. And we need to be careful about giving cats IV fluids. Remember, cats don't have the same blood volume as dogs on a per kilogram basis, and and we need to be very cautious about how we give fluids to cats. But these findings are just real interesting. There were some factors that decreased the risk in cats. Checking a pulse, well, thank goodness, people are still doing physical assessments and the use of pulse oximetry. And the reason I don't have any other monitoring tools up here in these mortality studies is that they weren't using them. The numbers of people that were using ECGs and end-tidal CO2 monitors and blood pressure monitors in these animals were such low numbers that they weren't able to include them in the mortality findings. The only thing that they were able to use in the cat study was the pulse oximeter because they had enough numbers to be able to use it, and they found that the use of pulse oximetry decreased mortality. I just thought it was kind of sad that the numbers of monitoring tools was too low in the other studies to be able to be used. One more study and then I'll go to more interesting stuff. This was really interesting. This study just came out in Veterinary Anesthesia and Analgesia this month. Or last month rather, January of 2012, there was a study that they did between 2008 and 2010, 3,500 animals. The overall death rate, 1.3%. Yikes. And this was a veterinary referral center in France. Healthy animals, 0.12%, about the same as the other studies. Sick animals, almost 5%. Don't be a sick animal in France. Not at a referral center. So what I got from these are that we're not doing any better than we did 20 or 30 years ago. And cats are still worse off than dogs. Older, sicker animals and small animals are still pretty likely to die, and we still have a long way to go on improving mortality rates. So what are some of the things we can do? Know our patient's physical status. Pay attention to things like how old they are, how sick they are. Come up with a drug plan that fits that patient's status, and prepare for these challenging cases. And if you can, have the members of your technician and veterinary team all involved if you have a challenging case, because boy, I count on the techs a lot. And the older I get, the more I count on them, because I'm aging just like these animals are.
Hey, PK, and did they define death in those patients? Was it just animals that were under anesthesia, or did they look at animals that died within a certain number of hours at the end of anesthesia?
Within a certain number of hours, just in the short recovery period, I think. Here I have these studies here, but it was anything that was strictly related to anesthesia, and they looked at sedation and anesthesia, not related to what was being done diagnostically or surgically. So they had some, and they were case control studies. They didn't just go back and look retrospectively. They seemed to be fairly well done studies. Broadbelt initially had done these studies in horses, and then he expanded it to dogs and cats. But yeah, and the other thing is pay attention to real subtle details, especially on these older, sicker animals. We pay a lot of attention to just subtle changes in these patients' statuses when they're under anesthesia. Of course, on the history, we look a lot at these guys, especially if they're getting drugs, and these patients come to us with a lot of drugs, a lot of non-steroidal anti-inflammatories these days, a lot of herbal supplements, a lot of cardiac meds on board. And we don't ask the owners, just about drugs. Ask them, if there's anything that they're giving their animals, from supplements to herbs to anything. Breed, there are a lot of breeds that I will just look at the animal and say, go through your breed Rolodex on cardiac diseases, Dobermans, boxer dogs, these little Cavalier King Charles. From the cat standpoint, in some of these purebred cats, if they start to hit middle age, I start thinking cardiomyopathy. There are an awful lot of breeds that will just make me start thinking about cardiac disease, and I would rather rule out cardiac disease in 30 patients than miss it in one. And think about when the procedure that we're going to be doing. There are a lot of animals that come through that get outpatient radiographs. We do an awful lot of outpatient radiographs that we do sedation for, and so we try to match the degree of sedation to what we're going to be doing to that patient that day. And you guys all see little guys like this, mean little dogs that come in. They probably have some kind of mitral insufficiency. They need to have something done to this probably needs to have, knee surgery or something. It has a mitral murmur. It's meaner than snot, and what are we going to do to it? We're going to need to sedate it. We need to get an IV catheter in it, and we need to then anesthetize it. So that's one example of a patient that we're going to be dealing with. And then we have this cat that comes in. It's overweight, it's diabetic, and its BUN and creatinine are higher than it should be. So we've got several problems there. This cat would, if you've got diabetes, you've got chronic renal insufficiency, and you're overweight, what physical status would you assign a cat like this? It's a 3. It's got systemic disease. It's more than localized, but it's not a constant threat to its life. But these are all problems that make us say, okay, this is not a normal healthy patient. I'm going to have to do special things with this cat. This cat's anesthetic risk is increased because it's a cat and it's got systemic disease, and that automatically tells me that this is a higher risk animal than what I'm used to doing. I'm going to have to do something special to this cat, and I'm going to have to pay more attention to it than I would a 2-year-old normal healthy cat. This breed right here, everybody that works with me knows that this breed is perfect in every way. Not only are they the best pet in the world, and this happens to be one of my dogs, but they're good customers. I mean, what more could you ask? Because they get cancers, they get heart disease, and so they come in and I say, boy, what's this guy going to be bringing today? Well, this was one of my dogs, and he had VPCs, and he also had mast cell tumors. So, those are both things that are going to say, boy, I'm going to have to deal with these problems. And plus, this picture was taken when he was about 11 years old. I'm going on 12, so there we are, increased anesthetic risks, special things that I'm going to have to do with this perfect dog. Perfect in every way. So physical exam. I spend a lot of time listening to these guys and telling the technicians to listen and feel pulses at the same time. We had a dog in today that if I hadn't been listening to the heart and feeling the pulses at the same time, I would have missed the fact that things didn't match. And we only have this happen about once in every 100 or 150 dogs that things don't match. But this dog didn't match so much that I didn't anesthetize her because anesthesia scares me. And this dog had really something bad in its heart to the point where it needs an echo before we anesthetize her. So, and I asked the techs to come listen to this dog and feel the pulses at the same time. She had a big mitral murmur, and her pulses didn't match her heart sounds. Her pulses would be weak, strong, then miss a beat, then a few really good ones, and then a nice strong one, and then miss a few. And her ECG didn't necessarily point to the fact that she had anything too abnormal going on. She didn't have ventricular ectopy, but she had abnormal rhythm. So we try to feel the pulses while we're listening to the heart sounds. We pay a lot of attention to that rhythm and those pulses at the same time. There's no hard and fast rules for objective evaluation. There has been no definite studies showing a correlation between chemistry evaluations and anesthetic outcome. So really just base your chemistries on how the animal presents and what you need to be doing to it, and you know, whether or not the animal's critically ill. We do a lot of pre-anesthetic BU and creatinine because we see a lot of animals, again, on non-steroidal anti-inflammatories, and we want to know what's going on there. Same with liver enzymes. If I'm doing anesthesia for a surgery that's going to have any degree of hemorrhage, we'll get a baseline PCV and total protein. And then if the animal's critically ill, again, we'll get more information. And then based on the animal's history, physical information, and objective information, then I'll assign it an ASA risk status and make the anesthetic plan from there. And again, this is just another reminder of what that ASA physical status is. And I try to get the techs to stick their necks out and circle a number, but most of the time they won't do it. Most of the animals that we see here are 2s and 3s. Most of the time we'll see a lot of orthopedic injuries here that are ASA status 2s. We see a lot of animals that are have systemic disease, and we see a fair number of animals that are ASA status 4s. Fasting rules have changed a little bit over the past years. Most of the time we just recommend fasting from food now, and 6 to 8 hours is usually plenty. We found that if you fast them too long, they seem to have an increased risk of regurgitation rather than a decreased risk, and we don't necessarily recommend fasting from water at all. So leave the water there and fast from food for about 6 to 8 hours. And if you have one of those tiny little 2-kilogram pocket dogs, we don't necessarily recommend very long fasting for them because they tend to become hypoglycemic. Also, if you have a pediatric patient, something less than about 10 weeks old, we don't recommend prolonged fasting in them either for the same reason. The monitoring that we typically use here is listed. We typically monitor their cardiac rate and rhythm with an ECG, their blood pressure. We use pulse oximeters and end-tidal CO2 measurement. We give IV fluids, but we don't necessarily give high rates. We'll usually use somewhere in the 3 to 7 mils per kilo per hour rate unless we see them start to lose a lot of fluids, and then we'll replace. We tend to use lots of opioid analgesics as CRIs and epidurals when it's appropriate. The major systems that I'm going to talk about tonight, I'm going to spend most of the time on the cardiac system because that's what I get the most questions about. That's what causes us the most angst, and that's what we see the most problems with. I'm going to spend some time on respiratory system, a little bit on gastrointestinal issues, and a small amount of time on renal and hepatic and endocrine systems. So the reason I'm going to spend most of the time on the heart is because anesthesia messes up the cardiac system quite frequently, and because we frequently see animals that have cardiac issues. It's the most impacted by anesthesia, and not just the heart, but the cardiovascular system, the blood vessels. We see lots of issues with cardiac rate and rhythm and blood pressure. So most of the time, again, we try to check the heart rate once the animal has gotten into the hospital and calmed down some. And we try to maintain that heart rate as close to that calm, awake state as we can, or slower. Most of the time, a slower rate is better. But there are some times when we do like a high heart rate, and that tends to be pediatric patients because their cardiac output is heart rate dependent. So we try not to let pediatric patients get bradycardic because they will become hypotensive. And the other exceptions to the slow heart rate rule are cats and those little pocket dogs. Cats tend to also be rate dependent for cardiac output. As soon as their heart rate tends to slow down, they become hypotensive. And to me, a bradycardic cat is usually a cat that's slower than about 120. I usually start to see them becoming pretty hypotensive if their heart rate starts to get below about 120 under anesthesia. This is just normal sinus rhythm example in a dog. This is an example of normal sinus rhythm in a cat. Dogs can have a sinus arrhythmia associated with respiration. I'm going to go through the common arrhythmias that we see in anesthesia. This is by no means an exhaustive arrhythmia, and I am certainly not a cardiologist, but this is just what we commonly see in animals that we anesthetize. And most of these problems are things that we cause by giving these animals drugs and anesthetizing them. The things that we usually see are sinus bradycardia, second degree AV block, tachycardia, and ventricular tachyarrhythmias. Sinus bradycardia is usually just defined as a heart rate in a dog, usually of less than 60. Usually we're causing that by some drugs that we've given them, and the most common causes are opioids, these alpha-2 adrenergic agonists, and occasionally propofol can do this. It's commonly seen too in animals that are hypothermic and or too deeply anesthetized. If you see it associated with hypoxemia, you're really in bad trouble. But most commonly, it's the drugs, usually. I don't always treat bradycardia, and that really makes our technicians really nervous. If I have a really big dog and he has a slow heart rate, and everything else is fine, his blood pressure's fine, his color's fine, his pulse ox is fine, and he's a happy dog, I just let him have a slow heart rate. As long as he doesn't have secondary AV block, as long as his heart rate is not less than 30 or 40, doesn't look like a horse. If his heart rate is humming along in the 50 to 60 range, and his blood pressure is fine, and he's a newfie or something, he's fine. The techs are nervous, but he's fine. Sometimes I'll let them give glycopyrrolate just because the techs are nervous, and they'll stop bothering me. Yeah.
How do you make decisions in reference to using anticholinergics as a pre-med based on like heart rates?
I'm not talking about drugs now. I'm talking about drugs in June. No, I'm kidding. Yeah. Anticholinergics are a huge area of personal preference a lot of times, and whether or not you use an anticholinergic as a pre-med depends on what other drugs you're giving as a pre-med, what the animal's resting heart rate is, if it's a small dog, a cardiac healthy dog, or a cardiac unhealthy dog. If I have a dog with mitral insufficiency and his heart rate's already 180, I'm not going to give him a pre-med of an anticholinergic. If I have that same mitral insufficiency dog and I'm going to give it, say, an opioid as a pre-med and his heart rate's only 110, I might give it glyco and hydromorphone just to offset the bradycardic effects of the hydromorphone, especially if I know I'm also going to be inducing him with something that's going to slow his heart rate. So it really depends on the entire anesthetic plan and what the dog's heart rate is to start with, what size that dog is, and what his cardiac health status is. So it depends. So, and that brings me back to what's this dog's ASA status, what is his heart status, and what am I going to be doing to it from the drug standpoint?
For healthy, happy dogs.
For healthy, happy dogs, I generally do not pre-medicate with anticholinergics anymore. I used to.
Heart rate is to begin with anyway.
Yep, unless their resting heart rate is really, really slow. Yeah, but you know, most of the time, and we all know this because we've been doing this for a long time, some of us, you can do a lot to an animal from the anesthetic standpoint, and they can tolerate it. So if you want to pre-med that animal with atropine and hydro, he'll be fine, because he's going to be tachycardic for a little while, and then his heart rate's going to slow down because the atropine's going to wear off. Or if you want to pre-med him with glyco and hydromorphone, same thing, because these drugs wear off. But if you want to pre-med that animal with atropine and hydromorphone and then induce him with ketamine and Valium, that guy's going to be tachycardic for a while. And that tachycardia makes me more nervous than that dog with a heart rate of 50 with good blood pressure. Because myocardial oxygen consumption is going to be a lot higher in that tachycardic animal than in that nice slow heart rate, as long as blood pressure's good and everything else is happy. Yeah, most of us over the years have learned that we're happier with a slow heart rate most of the time, with some of these exceptions, than we are tachycardia. Yeah. And most of us have come to use anticholinergics only when we need them. Yeah. So again, here's treatment of bradycardia. Depends on the cause and the severity. So if your cats start to get a slow heart rate and they're hypotensive, most of the time bumping that heart rate up will at least partially help that hypotension. And if you do have bradycardia, especially if you're also hypotensive, try an anticholinergic first. And the one that I usually will reach for is glycopyrrolate, because it usually will not jack their heart rate up to 200 or so. The exception there is if I have a life-threatening bradycardia, atropine is usually the drug of choice. But don't forget too, if your animal is bradycardic and you give them an anticholinergic and it's not working, the reason the anticholinergic is not working is because of lack of sympathetic tone. And the reason they don't have enough sympathetic tone is because they're too deep. And usually the reason they're too deep is because they're cold. So if you have a cold animal, most of the time your anticholinergic is not going to work, because all it does is get rid of parasympathetic tone. It will not enhance sympathetic tone if the sympathetic tone is not there. So you may have to give something to improve sympathetic tone. And that's when we usually reach for inotropes. Or at least dopamine, because dopamine, in addition to being an inotrope, has chronotropic activity, meaning it will increase the heart rate in addition to improving contractility. And it does that by acting on those beta-1 receptors in the heart to increase heart rate. But you shouldn't just make the heart beat stronger and faster without fixing the problem, and that is decreasing your depth and trying to warm that animal up. So another problem that we commonly cause in anesthesia is second-degree AV block, and that's usually a slow rate, and that's a block. Here's P wave, no QRS, another P wave. Here it is again. And the most common cause of this is usually things that, again, enhance vagal tone and slow that conduction velocity between the atria and the ventricles. Same drugs that cause bradycardia will also do this. The opioids and the alpha-2 agonist. And again, treat it with anticholinergics. The problem here is, and I don't know how many of you guys have had an ECG on the animal and have seen this happen, but anticholinergics will transiently cause a second-degree AV block to get worse before they get rid of it. And if you don't wait that out, it will make you really, really nervous, because you sometimes will have a string of about 4 to 6 P waves in a row with no QRS. And you think, man, I've just made it worse, I need to give more anticholinergic. And then before you know it, your AV nodal rate will catch up, and you really will have a heart rate of 200 or 220. So if you give the anticholinergic, especially if you give glycopyrrolate, it takes several minutes sometimes, and sometimes it will transiently make that second-degree AV block worse before it makes it better. So you need to probably be patient, and it's kind of scary. Sinus tachycardia is the other end of the spectrum here that we see in anesthesia. Sinus bradycardia and second-degree AV block are usually pretty easy problems to fix. It's usually pretty easy to increase that heart rate. If you have a tachyarrhythmia, if it's not caused by pain or the animal being too light or hypovolemia, it's usually not always that easy to fix. Sometimes you have to just wait it out, especially if you've caused it by giving an anticholinergic or giving ketamine. You just have to wait until the drugs wear off. But try to run through that list of possible causes of the tachycardia and see what's causing it. And if you haven't caused it by one of these drugs, if it's hypovolemia or pain, then those are things that you can treat. So again, the tachycardia treatment depends on the cause. So ventricular tachyarrhythmias, this is just an example of single PVCs here, 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 and here. And then ventricular tachycardia is just 3 or more VPCs in a row. Ventricular tachycardia is usually not something that we cause in anesthesia. Now that we don't have thiopental and halothane anymore, this is not usually something that anesthesia causes. This is usually something that we see the animals present with, and it's usually caused by myocardial trauma or myocardial disease. And these are usually the things that we see it associated with. Hit by car animals, we see it fairly commonly with GDVs, splenic masses, and unfortunately we see it in some breeds of dogs. If I see animals that present in anesthesia, and these arrhythmias, these ventricular arrhythmias are fairly frequent, if they don't conduct a pulse, if I don't feel a pulse with these, if they're associated with a high heart rate, I'll usually treat it. If I just see these very infrequently, like if I have a boxer dog come in and he has 1 or 2 a minute, I don't get too hepped up about it. But if that boxer dog has a lot of them, and I'm not going to go look in the textbook and say, oh, it's got more than 15 a minute, I'm going to treat him. I'm going to just look at the overall dog and say, boy, he's having a lot, his heart rate's high, and he's not conducting a pulse. I'm going to treat him. And my drug of choice is usually a slow bolus of lidocaine. And I'm going to really hope that that is going to suppress them, because that's my favorite drug to give. And then I'm going to put him on a CRI. And the nice thing about lidocaine is that it, in addition to treating that ventricular tachycardia, if that animal has a GDV or a splenic mass, it's also going to help with pain relief during surgery. And it's got some anti-endotoxic effects. And I'm even going to use the lidocaine as part of my induction regimen. You guys will see for a lot of these GI abdominal exploratory. So it's got lots of nice effects, in addition to usually suppressing true ventricular tachycardia. Now, if these are some of these accelerated ventricular rhythms, lidocaine will not usually be effective in treating these guys. So, blood pressure issues. Hypotension is really common, and usually if I've got mean arterial pressure for, say, 10 or 15 minutes of less than 70 millimeters of mercury, I will usually treat it. Most of the time, simply decreasing the inhalant, giving some fluids is usually going to treat it. And if that does not do it, and I have a sick animal, I will usually be pretty aggressive about giving inotropes. If it's a normal, healthy patient, sometimes we'll just sit on that patient and wait till the surgery starts. But if it's a sick patient, again, we're usually going to be more aggressive about trying to get that blood pressure up pretty quickly. Again, the inotropes are going to enhance contractility in the heart. If you just want to increase blood pressure, we usually give dobutamine. If we want to increase both blood pressure and heart rate, we usually use dopamine. These are not difficult drugs to use, and they're really not scary drugs to use. You just have to put them in a bag of fluids and give them as a constant rate infusion. So if you have an IV pump and you have a bag of D5W, it's not hard at all to give these drugs. And it is amazing how fast the blood pressure will go up. It'll go up to normal, and it will usually stay normal the entire surgery. And if you turn the dopamine or the dobutamine off, it's just as amazing how quickly the blood pressure will go down. That's why anesthesia is so cool. So acquired valve disease, the little dogs that come in, they've got mitral insufficiency. Try to determine how severe it is. If you've got these guys on their cardiac meds, leave them on their cardiac meds. They usually look kind of like this. And their moms love them very much. Sometimes these cardiac meds like pimobendan and enalapril, they may make these guys a little bit more prone to being hypotensive, but we can deal with that. And what we do from the anesthetic standpoint really depends on how sick they are. If they've just got a murmur and they've got no real cardiac failure, I don't necessarily treat them that much differently than I do a normal dog, except we avoid fluid overload and we watch their blood pressure. And we try to maintain their heart rate pretty close to whatever it is when they come in and get calm. So that's kind of how we treat them. But if they're kind of sick, then we'll give them an opioid, and there's the answer to the anticholinergic question. If their heart rate's kind of slow, we might add some glycopyrrolate to that opioid. For induction, we'll give them a benzodiazepine if they're not permanently back ordered, and probably pre-oxygenate them if the dog will tolerate it. If the dog gets all stressed out by a face mask, then don't try to pre-oxygenate them, and we'll give them propofol. Etomidate is much less expensive than it used to be, and if they are in heart failure, we will, after the benzodiazepine, induce them with etomidate. But I'm talking heart failure and not just a murmur. They really will do quite well after an opioid pre-med. And the opioids that we'll usually use, oxymorphone has become available again for those of us who used to use it a long time ago, and then it wasn't available. It's available again, and it's a really nice drug. Or hydromorphone are the drugs that we'll typically use. They don't tend to puke as much with those two drugs as they do with morphine, but they still will throw up some. And neither of those drugs is too outrageously expensive. And then for induction, I'll usually just give them a dose of Valium. And the Valium lets me use less propofol, and it keeps them from waking up every 2 minutes after the propofol, which is really nice.
So for dogs that have valvular disease, do you think about cardiac function as being more rate dependent in those dogs? Because you talk about dogs in general, cardiac function is not so rate dependent for a sizable dog.
Yeah.
If you have valvular disease affecting cardiac output, do you think about them being more cardiac rate?
I think more about Starling's law when I have animals that have valvular disease, because if they get too fast, I think about them going on the downward slope, the failure curve on Starling's law, and I've seen that if they get too slow, then they just don't have enough oomph either. But these are the dogs, again, that I'm going to probably already have dobutamine hanging up, and I'm not going to be shy at all about using it. If we put these dogs under anesthesia, and they're usually going to be under anesthesia for a degree of time, and their heart rate is in the 50s and 60s, I will go ahead and put them on an inotrope and support their contractility, because I know their contractility is probably not going to be great. Isoflurane causes dose-dependent vasodilation and decreased contractility, and it is the most, it has the narrowest safety margin of any drug that we use, the inhalants. And I just can't stress that enough. And the sicker the animal, the more isoflurane and sevoflurane depress cardiac function. And from the cardiac standpoint, there's really no difference between isoflurane and sevoflurane. And so neither one of these drugs is great. And so we do everything we can to decrease the amount of drug that we use by giving these animals benzodiazepines and opioid CRIs and epidurals, and putting them on inotropes to support cardiac function. And we just do it pretty aggressively. Yeah.
Seems like I heard you say you gave diazepam before you gave the propofol to these.
Yeah, for induction, and the reason we do it is because diazepam has a wide safety margin and propofol has an extremely narrow safety margin. And the diazepam also will let me, in about 3 to 5 minutes, the propofol is going to start wearing off and the animal's going to start wanting to wake up. And that has not been long enough for the isoflurane to start getting into the animal and go into its brain to make it unconscious. And so the Valium just lets me smooth out that transition between propofol induction and isoflurane maintenance. And it lets me do that safer than straight propofol.
You don't have to give as much propofol.
I can give about 25% less, and that's a pretty significant reduction in the propofol for a pretty safe drug. When I'm thinking sick animals, I start thinking the drugs that I want to use, opioids and benzodiazepines. And the drugs that I want to use less of, propofol and the inhalants, and most of the other induction drugs. I would like to use probably less of the ketamine, even though it's probably got a wider safety margin in most instances than propofol does. And I'd, if thiopental were still around, I would like to use less of it. I probably would avoid the alpha-2 agonist in sick animals. I would avoid acepromazine in the sick animals. So that's the Rolodex, and it's really pretty simple. Sick animals, here's my list of drugs that I don't want to use, and here's my list of drugs that I do want to use. And how can I decrease the drugs that I still have to use in order to achieve induction? And I'll use benzodiazepines and opioids, and you'll just see it's kind of a broken record over and over again. You'll see benzodiazepines and opioids in these sick animals, almost regardless of what the illness is. And for these guys that I taught at Mississippi State, they kind of know me. They could probably get up here and teach this. Yeah. Because the benzodiazepines, we use them, they're not going to achieve anesthesia by no means, but they're really going to let us decrease the dose of those drugs that do achieve anesthesia but have narrow safety margins. The biggest problem right now with Valium and midazolam is that they're getting hard to get. We're kind of looking at drug shortages. Okay, so dilated cardiomyopathy. The good news is that we don't usually anesthetize these guys because they're quite sick, but their biggest problem is horrible contractility. But every now and then we will get one of these guys in. I have anesthetized Dobermans with dilated cardiomyopathy that would come in with a GDV, and that's a really bad combination of problems to have. Sometimes they have tachyarrhythmias, and we'll need to treat those, and we'll use combinations of drugs to decrease, again, the dose of those not so safe drugs. again, pre-med with an opioid. I try to pre-oxygenate them. Now, on these guys, if they're not really tachycardic, sometimes I will add a tiny dose of ketamine to their induction technique because it sometimes will enhance contractility. But I'm not talking about our regular induction dose of ketamine. I'm talking about a really low dose, like maybe 1 milligram per kilo, in addition to the benzodiazepine. And a lot of times I will induce these guys with fentanyl in addition to the benzodiazepine and ketamine. And here's the lidocaine again. Again, inotropes to support contractility. So what about the cat that has too much contractility? So you want to avoid drugs like ketamine in these guys because they, again, will increase oxygen demand and cause tachycardia. So here we are again, the same list of drugs that I used in most of the other sick animals. If I have a cat come in with that heart murmur and she's got a high T4, she might be on methimazole to try to lower her thyroid levels, but we're concerned about her being hypertrophic. I'll probably give that cat some oxymorphone as a pre-med, maybe a little bit of midazolam, but if you don't have midazolam, just give her some oxymorphone. Get a catheter in and pre-med her with a little bit of Valium and propofol and put her on inhalant. We use a lot of fentanyl CRIs in cats, works quite well. And fentanyl is a really inexpensive, reasonably easy to get drug when it's not on back order. If you have a DEA license, we get it from Butler Shine and MWI. So what do you do with the boxer dogs that have boxer cardiomyopathy? Pretty much the same thing. Control the arrhythmias, pre-med them with opioid, especially if something painful is going to be going on with them, and use a lidocaine CRI. Any questions about cardiac issues?
I have a question.
Yeah.
So are you not giving 3 doses of lidocaine first for VPCs before you put them on the CRI?
No, not in anesthesia.
1. and
No.
then put them on.
Yeah, Stephanie asked if I'm giving three boluses of lidocaine before I put them on a CRI. Not in anesthesia because I'm just going to go ahead and put them on a CRI because it's going to lower my inhalant requirements. It's going to provide analgesia, so I'm just going to go ahead and put them on a CRI because it does so many good things anyway. I'll just give them a single bolus and put them on a CRI. Aside from animals that have really bad heart problems, animals that have really bad respiratory problems also tend to make me nervous. They probably make you guys nervous too. So I learned that it's not cool to say cool now. You're supposed to say nasty. So it is not nasty to see animals that have respiratory disease. So if you see a cat and it sounds like it looks like that, you might want to just send it somewhere else. The problem is I can't do that anymore. Yeah. So this would be the cat that comes into your clinic and it has finally stopped hiding the fact that it's got 90% occlusion of its upper airway. And this is about a 15-year-old cat that was open mouth breathing. And the problem with these guys is that you have to be able to anesthetize it, but it has to keep breathing because you might not be able to get an airway and breathe for it, and that's a problem. That is just not cool. So what we're looking at is we are looking from the mouth of the cat. This is a laryngoscope. And for anybody who thinks it's not cool to use a laryngoscope, laryngoscopes are nasty. They are way cool. So the first thing I would tell you if you are going to do anything in your practice is if you do not have a laryngoscope, it's like being a carpenter and not having a hammer. It's like trying to nail something into a piece of wood using your shoe heel. You know, don't be that cool. I am so uncool because I use laryngoscopes all the time. I like to see what I'm doing. And because the older I get, the less well I see. And Stephanie says I'm intimidating when I look over my glasses. So I use laryngoscopes and I change the blades all the time depending on how far back I need to look. So get one. And don't do like I did a few years ago and don't buy the cheap one on eBay because they don't work very long. I learned that the hard way too. Go ahead and get that Welch Allen. Spend the bucks because the little lights are a lot easier to replace. And the blades will come on and off a lot better. And they are just a very nice lifelong investment because when you get in trouble and you need to be able to see fast, that will get the job done for you. So we are looking from the mouth and there's just not a lot there. And the only place we can get anything in this cat is about right there, and we can only get something about 2 millimeters worth in that cat. And we didn't even know that until we anesthetized it, and it had to keep breathing. So this is when it's really, really important to get everything you need before you ever give any drugs to the animal. If they've got bad airway disease, get all your airway equipment, get lots of different sizes of endotracheal tubes, get suction, oxygen, and your monitoring equipment ready. Because as soon as we touched that mass, it started bleeding, and it completely occluded everything. But we were able to get a tube in. And the problems that we usually see in the laryngeal region are either masses like this one, or we pretty commonly see laryngeal paralysis. So we need to have them lightly anesthetized and still breathing. We have to have suction ready if they're going to be bleeding. And so what we normally do is, if it's a dog and we think it's got laryngeal paralysis, most of the time this is where we do use a little bit of ACE just to calm them down. Pre-oxygenate them if they'll tolerate it, and then give them propofol, but we're very careful about titrating the propofol to effect. And if it's a laryngeal exam, we will use doxapram just to make them breathe heavy, just to be able to look at laryngeal function. And the dose is about 0.5 milligram per kilo, just to look at laryngeal function to see how well they're breathing. Now, if it's a cat with a laryngeal mass, I'm real hesitant to use propofol because you don't know if they're going to stop breathing or not. And etomidate is my drug of choice on cats with laryngeal masses because they'll usually keep breathing. And that drug is just a great drug for animals that have really bad heart disease and animals that I don't know if I'm going to be able to intubate or not. So I've got propofol down here, but that's mostly for dogs that have laryngeal paralysis. Because you can intubate a dog with laryngeal paralysis. You don't know if you can intubate these cats that have their trachea covered up with a mass. These little dogs that have tracheal collapse, most of the time you just need to minimize stress in them, and usually that means giving an opioid, and most of the time butorphanol works just great unless they're having something really invasive done from the surgical standpoint, and then we'll use some more of a mu agonist. Diaphragmatic hernias can be a really mild issue, or they can be life-threatening, and usually the dog or cat will tell you pretty quickly how their own condition is. If they're having a problem or not, you can usually tell it. I'll usually get catheters in these guys and give them everything IV. And again, usually an opioid for the pain associated with the surgery, a benzodiazepine, again, just to decrease the dose of the induction drug, and propofol, not because we think it's safe, but because it is rapid and it lets us rapidly control their airway. And as soon as we get an endotracheal tube in, we're in control of breathing, and that's what we want, is for us to be in control of breathing for them. And the techs get nervous and they say every now and then, but it's not breathing. Well, we're in control of breathing as soon as it's intubated. We are human ventilators. And so as soon as you get the propofol in, you can start breathing for the animal, and we are controlled ventilation. And as soon as the animal is anesthetized, we put a pulse ox on it and entitle CO2, and we will have emergency support ready. Sometimes you have to sit these animals up like this to get them clipped. We get them clipped as much as we can before we anesthetize them and have emergency equipment ready, because sometimes they will do quite poorly as soon as we anesthetize them. Sometimes they do quite well and we don't have any problems at all, but sometimes they do pretty poorly. Sometimes we're the problem, and I unfortunately have either seen or done a number of these iatrogenic problems, and so I will tell you about them and caution you because I have been there. Sometimes it's a numbers issue. I've had this RMM cartoon forever, but I still think it's kind of funny. So again, we talked earlier about cat mortality and intubation problems. Just be very careful. When we intubate cats, we use a tiny little bit of lidocaine. The other problem with trying to intubate a cat is a lot of people will try to intubate them when they're still too light. You got to get them deep enough so that they're not trying to respond. You have to make sure that they're not going to go into laryngospasm. We also, I don't use those red rubber endotracheal tubes anymore because they're pretty stiff, and the cuffs are really pretty high pressure cuffs, and that puts a lot of pressure on a really vulnerable and fragile trachea, and that is the reason sometimes that they tear. I try not to use stylets because that's also been associated with some of these professional liability lawsuits are stylet associated tracheal tears. Very, very cautious about adding air to the cuff. We never just intubate and automatically inflate the cuff. We always check for leaks to see if we need to inflate that cuff before automatically inflating.
So what's your criteria for that? Like you're closing the pop-off valve, squeezing the bag up to 20?
20, yep. And on a cat, 15 to 20. And as soon as you reach that, you don't need to inflate anymore. And these small endotracheal tubes don't take much air at all, half a cc. And if you are checking these endotracheal tubes before you ever put them in the animal for leaks, just look to see how much air you're putting in them to begin with. You don't need much air anyway. And then once you put them in the animal, you insert and only put it to here. The thoracic inlet, and then close the pop-off valve, and just takes a few seconds, and listen there, check for leaks, and if you can hold 15 to 20 centimeters of water without hearing that hissing sound, only add enough air to stop that leak and then stop adding air. Yeah, and it's really easy. It's just as easy to do that as it is to just, it just drives me nuts to see somebody just shoving air into an endotracheal tube. The other thing that drives me nuts is to see somebody using that flush valve right after induction to fill up the bag. Don't do that either, especially in a small animal, because you can do this right here. And we have done that. We blew out the cat's mediastinum, we blew out the cat's lungs, and we caused subcutaneous emphysema by too high a flow rate and a closed pop-off valve. So this is just absolute, that wasn't here, that was elsewhere. This is just absolute iatrogenic barotrauma. And then we took a radiograph of it. So, you know, this is just a bad thing to happen. So be very, very careful, especially in a cat. The cat lived after spending several days in ICU, but just don't do as I do. And so what do we do here? This is a little pug puppy that came into, and this wasn't here either. I will say I learned a lot of lessons before. This is the endotracheal tube, and it's way down a bronchus. So again, only insert to here. So we kept wondering why this puppy's pulse oximeter was reading in the low 90s instead of the high 90s, and it kept huffing and puffing and trying to be light. And we finally figured it out, or the radiologist figured it out for us. We had that tube way too far in. So measure from the tip of the nose to the thoracic inlet. If you have your tube sticking out here, it's not going to kill the animal, but it does increase dead space because it increases that distance before it separates and you have no mixing of CO2. So just go from here to that thoracic inlet, and then you won't have an endobronchial intubation. Again, that was just another iatrogenic problem, and this is just a problem waiting to happen. This is just an obese brachycephalic pug that's so fat she's on oxygen before she ever even came to us. GI issues, usually they're kind of fun because usually the animal has eaten something, twisted something, got something kind of bad. Abdominal exploratories can vary from a normal healthy patient that just ate something the day before to a life-threatening GDV or a splenic mass. This is a GDV. Dr. Calfee talked about the surgical issues associated with them last month. This is a humongous splenic mass. We usually put really big catheters in these guys. They're usually big dogs to begin with if we have an animal with a hemoabdomen or a GDV. But basically, from the anesthetic standpoint, we handle them pretty similarly. We handle them as though they were, and they are, hypovolemic, painful animals. Usually try to put an ECG and blood pressure on them while we're getting them ready. Because they're frequently tachycardic and they frequently are having ventricular tachyarrhythmias. We usually give them fentanyl. It's kind of my favorite narcotic or opioid. We give them lidocaine. Again, here's the benzodiazepine again. If they're not too tachycardic, I'll give them a really low dose of ketamine and then induce them with more fentanyl. If time permits, we'll do an epidural, and then we give them a CRI of fentanyl and lidocaine. If they are hypotensive and we are getting as much fluids into them as we can, and fluids would usually be crystalloids and hetastarch, then we'll add inotropes to support their blood pressure. And I'll usually decrease the inhalant as much as I need to get their pressure up, and sometimes that's as low as 0.5%, and sometimes that's 0% inhalant if they just cannot tolerate the isoflurane. And then usually if it's a GDV, we have to pass a stomach tube intra-op. And post-op, we'll continue their fentanyl and lidocaine, continue their fluids, and keep monitoring for arrhythmias. And if they need it, we'll put nasal oxygen in. Most of the time, if they're having issues with inflammatory bowel disease, their biggest problem is hypoalbuminemia, and sometimes they're really thin. So sometimes we need to give them hetastarch, but other than that, they usually do pretty well. Renal disease, most of the time, the biggest issue with renal disease is keeping them from becoming hypotensive. And we don't want to make their renal disease worse. We used to have some anesthetic drugs that were bad on the kidneys, but there aren't really any drugs that are contraindicated in animals with renal disease. If you have a cat that has renal disease, keep in mind that ketamine is primarily renally excreted unchanged, so that animal might take longer to recover if you use ketamine in it. But other than that, there aren't any contraindications. The biggest thing to keep in mind with the kidneys is hypotension and hypovolemia are things that you need to avoid, and non-steroidal anti-inflammatories are things that we avoid in animals with renal disease. Most of the time, if I have an animal that's azotemic, we'll get it in early that day or the day before and put it on fluids half a day or overnight, depending on how azotemic it is, and get its creatinine as normal as possible. Sometimes it's impossible, but at least keep it on fluids and before it goes to surgery. And liver disease. I had a call earlier today about a dog that had a copper storage disease, and again the biggest thing is first do no harm, and so we try to minimize drugs that require a great deal of hepatic metabolism. But there's a huge difference between that normal healthy looking dog that just has a slight increase in liver enzymes, and you guys have probably all seen these. What do you do with the dog that looks normal and just has mildly increased liver enzymes? I don't treat them much different than I do a normal healthy dog. But then there's a big difference between them and the dog that's icteric, has a high bilirubin, or that dog that has liver failure, or the dog that has the shunt, and the ones that are normal. So if it's just a mild elevation, no other clinical signs, we just keep an eye on that, but anesthetically I don't really treat them that different. However, if they truly do have liver insufficiency, those are concerns. They might be hypoalbuminemic, they might be hypoglycemic, they might have issues with metabolism, and if they're truly in liver failure, they might have coagulopathies. So again, here we go, same old story. We use the opioids in these guys, and I do prefer propofol in these over drugs like ketamine, because propofol does have some extra hepatic metabolism. They have done studies showing that the clearance of propofol exceeds hepatic blood flow, meaning that it's going somewhere else for clearance. And in people, it seems to be renal. In cats, it seems to be lungs. And in dogs, we're not real sure. But it's going somewhere else other than just the liver. So we do prefer opioids because they're reversible, even though they are hepatically metabolized, and propofol because it does undergo extrahepatic metabolism to some extent, although most of it is hepatically metabolized. These guys may need plasma to support coagulation and albumin. They may need glucose if they're hypoglycemic, so we check their glucose levels. And if they're icteric, these guys tend to be in vasodilatory states. Icteric animals really make me nervous because they tend to be hypotensive and they may need inotrope support. And I did write our recipe for inotropes over there on the board. And if you have trouble understanding it, I can certainly go through that with you. About the only endocrine issue that we have problems with is diabetes mellitus, and it's pretty typical to fast the pet and give half of its normal insulin dose that morning, and then we check the glucose on the animal when it comes in and check it every hour. Most of the time they don't need glucose, but sometimes they do, and if they do need glucose, usually only add about 10 milligrams per meal, and then check their glucose about every hour. If you put these guys on 2.5% or D5W, they tend to get quite hyperglycemic. So there are some good resources. For those of you that are AHA hospitals, the AHA just came out, a couple of months ago with brand new anesthesia guidelines. Dr. Bednarski from Ohio State University, and his team just came out with some new monitoring guidelines. Our general anesthesia guidelines, and the ACVA also has monitoring guidelines. If you guys are interested, we can direct you to the website for the AHA monitoring guidelines. He really had, they did a great job for coming up with those guidelines there. To summarize, our anesthetic risk is still too high. The mortality rates are still too high, and they haven't really gotten any better in the past 30 years. So if we work harder at challenging cases, paying attention and prepping for those guys, and I think one thing, I think not having thiopental and halothane is probably going to improve things, I think. And I think the monitoring tools that we have available to us now that are reasonably priced and that more veterinarians are using, I'm hoping that the study that comes out in the next 20 years is maybe hopefully going to be more like 0.01%, more like human mortality than that 0.1 to 4% like we saw in the French study. So that would be a goal that all of us hopefully could reach for.